All right. Well, we are at 12 noon and we've got a packed agenda today. So I think we'll get started. I'll continue to admit folks as we're seeing them join us. So happy 13th annual Safety Net Clinic Week, everyone. We're very excited about this year's program. We're doing things a little bit different as a way to not only showcase some of the ways that we are supporting rural health clinics at the Rural Health Center, but also highlighting some really exciting initiatives happening at RHCs across the state. So we're going to have a pretty robust program today. We're going to have Michelle Mills, CRHC CEO, get us kicked off for our introductions.
Great. Thanks so much, Kelly, and happy Safety Net Clinic Week. I am Michelle Mills, and I'm the CEO here at the Colorado Rural Health Center. Appreciate you all joining us so much. We started this Safety Net Clinic Week 13 years ago, and really it is a way that we can have dedicated to promoting awareness and some of those unique challenges that are facing our rural health clinics and other rural clinics and other kind of safety net clinics throughout Colorado. So we're really excited to have a diverse mix of attendees, including CRHC members, policymakers, healthcare organizations, advocates, some new faces, and some that are very familiar with Colorado Rural Health Center. So want to tell you just a little bit about us. So we are the State Office of Rural Health, as well as Rural Health Association in Colorado. We are one of three that is set up as a nonprofit. The other two are Michigan and South Carolina. So that makes us pretty unique, meaning that we can have great people like Kelly here to lead a policy program for us, not most others that are either located in state government or university model don't have that flexibility. Our mission is, as you can see here, to enhance healthcare services in the state by providing information, education, linkages, tools, and energy towards addressing rural health. I'll tell you that our mission and our vision hasn't changed in the 32 years that we've been around. So really super proud of that, and really excited that, the coalition that started the Rural Health Center back 32 years ago really had the foresight to know these things were important and that an entity like us was important to have in our state. So we have, you can see through the map here, we've got a lot of members throughout the state. The big white part is the I-25 corridor plus Grand Junction over there, but we serve people in all four corners of our state. Sometimes they take a little bit longer to get to than others, but really happy to be able to serve all throughout the state of Colorado. So some of what we do is this past year, we've been able to invest $5.6 million worth of grant funding into rural Colorado, really with the mission of trying to pass on those resources to our rural health facilities to try to make them more sustainable. Some of the programs that we have are for sure offering out technical assistance and outreach to hospitals and clinics, but we have a variety of educational events, including the forum, which is for clinics that we have in April. We have our annual conference located in October. We do workforce recruitment and retention, and we also do something called an APGAR assessment, which is related to workforce. We have a variety of quality improvement activities. We have health information technology and data projects. We offer out EMS training and support funding. We have policy and so much more that I don't want to bore you with all those things. So today's program here, you can see the list here of what we've got going on today, which is quite a number of people from our team, really trying to describe some of the key programs that we're really proud of, that we think you will be interested in, that impacts rural health clinics. And then also we're so honored to be joined by two rural health clinic folks to be able to describe some of their programs, just because we think it's so helpful to be able to hear directly from them and the great work that they're doing. Okay, so before we kick off this great program, I have the honor, although I don't like it. Thank you, Kelly, for reading the proclamation, which nobody wants to read because it's like so long. So please bear with me as I try to read this word for word, and apologize in advance if I stumble over any of these words. So, proclamation, which we are very honored to have from Governor Polis and his administration. So let's start off. So whereas community safety net clinics, federally certified rural health clinics, school-based health centers, family health medicine residencies, rural training tracks, and rural rotation sites all make exceptional contributions to the health and well-being of Coloradans. And whereas Colorado's school-based health centers provide primary health care, behavioral health care, and many more services at no cost. Whereas rural health clinics provide essential healthcare treatment and preventative services to vulnerable populations in rural communities throughout our state. And whereas community safety net clinics serve Coloradans who are uninsured, underinsured, or insured through public programs like Medicaid, CHIP Plus, and Medicare. And whereas Colorado's Commission on Family Medicine addresses Colorado's needs for well-trained family physicians and advanced primary care practitioners, particularly in rural and underserved areas. And whereas these settings were established by civic-minded individuals, healthcare professionals, and community organizations that recognize the need to ensure access to primary care services to individuals, children, and families in rural and underserved areas of Colorado. And whereas healthcare settings often lack sufficient workforce and technical resources, but are creating innovative solutions in delivering patient-centered care, high-quality care in efficient and effective manner. And whereas despite these challenges, these care settings provide essential healthcare treatment and preventative services to vulnerable populations and communities throughout our state. And whereas we express our appreciation and gratitude to these clinics who dedicate their time, energy, and resources to serving their communities, therefore, I, Jared Polis, Governor of the state of Colorado, hereby do proclaim August 14 through 18, 2023 as Safety Net Clinic Week. Phew, I made it. So with all that being said, we are really very honored to be able to have that proclamation of, even though I'll say it's a little difficult to read, but I'm going to pass it back over to Kelly for our very first presentation. So thanks again, everyone, for being here.
Awesome. Thanks, Michelle. And thanks so much to our participants today. Really excited to see some healthcare partners. We've got some CRHC members. We've also got some elected officials. So thank you so much to Representative McLaughlin and Representative Winter for joining us today. For those who don't know me, I'm Kelly Erb. I'm Associate Director of Policy and Advocacy at the Rural Health Center. I'm going to be leading our first presentation, just giving folks an introduction to what a rural health clinic is and briefly discussing some of our RHC policy priorities. A little bit of housekeeping before we get into things. If you have any questions or comments, please enter them into the chat. And at the end of each presentation, we'll kind of determine where we're at with time and see if we have a chance to answer those. If we don't, please know that we will certainly follow up with folks to provide additional resources and context. Okay. There we go. So the Rural Health Clinic. So the Rural Health Clinic program designation was created by Congress in 1977 with the support of President Jimmy Carter. The RHC program is intended to increase access to primary care services for patients in rural communities. We've got 57 RHCs across Colorado, and they really vary on what they look like. So RHCs can be public, nonprofit, or for-profit healthcare entities. RHCs can be housed in permanent structures or mobile clinics. We even have some RHCs in schools as a part of the school-based health center program. So really exciting. The only real requirement around RHC locations is that they must be located in a rural, underserved area. And as we're moving along through my presentation, I'll be highlighting some photos you see of some different RHCs across the state that I've had the chance to visit. So you're seeing Family Practice of Holyoke here. You're going to hear from Jaden later today. And then the SLV clinic in Antonito, you'll be hearing from some SLV folks just a little bit later. So more about RHCs. So RHCs are required to use a team approach of physicians working with non-physician providers, such as nurse practitioners, physician assistants, and certified nurse midwives to provide services. So you'll notice that rural health clinics really do depend on team-based care that utilizes those advanced practice providers. The clinic must be staffed at least 50% of the time by one of those folks, so an NP, a PA, or a CNM. And RHCs are required to provide outpatient primary care services and basic lab services. RHCs can also be certified as a provider-based or an independent freestanding RHC. So provider-based RHCs are affiliated with a parent entity, which is typically a rural hospital or a rural hospital system. Whereas independent RHCs are not affiliated with those folks. So we do have I would say the majority of the RHCs that are CRHC members are provider-based RHCs, though we have a handful of amazing independent RHCs providing access to care. And you'll see we've got Heart of the Rockies Regional Medical Centers, Saguache Health Center that was just recently designated as an RHC, and the Walsh Medical Clinic down in Southeast Colorado in Walsh. Okay, so the intended advantage of RHC status is enhanced reimbursement rates for providing Medicare and Medicaid services. So independent RHCs are paid a capitated all-inclusive rate, or AIR, of $113. Whereas provider-based clinics receive cost-based reimbursement that's determined by their parent entity. So based on the cost report of the rural hospital or rural hospital system that they are affiliated with. Either way, these rates often don't cover the cost of a visit. So RHCs are often dependent on a patchwork of variety of other funding sources, including grants, local support, donations, etc., especially if they want to implement or sustain any new staff or programming. Here you'll see Southwest Health Center, School-Based Health Center, RHC. This is in Cortez, Colorado. And then we've got the Eads Medical Center. Okay, so now we are shifting into the policy priorities portion of my presentation. Oh, excuse me. Okay, so workforce recruitment and retention. So a strong healthcare workforce is really fundamental to providing quality, timely care in rural Colorado. Rural healthcare facilities must have sufficient providers, administrators, and support staff to operate sustainably and meet the care needs of their communities. Access to rural healthcare is dependent on the availability of healthcare professionals, but unfortunately, the ongoing healthcare workforce shortage continues to be a challenge for rural communities across Colorado. So some significant workforce numbers from our snapshot you'll see are included. So recruitment for an advanced practice nurse or physician assistant is 6 months on average. It can take up to a year to recruit a physician to a rural community. 32% of nurses in Colorado are 55 plus, while over 4,500 nurses are 65 plus. It's expected that over the next 10 years, 2,000 nurses will retire annually, and we'll need 3,300 new nurses annually to meet any of those workforce gaps. CEO turnover is also a significant challenge. Leadership turnover, really a significant challenge for our rural hospitals and clinics. We saw a 28% CEO turnover in Colorado last year alone, which is higher than the national average of 18 to 20%. Okay, so on this side, you'll see access to care in Colorado, and notice that we have multiple counties without access to a healthcare facility. So workforce shortages impact the ability of these counties to provide healthcare, and they also impact the ability of counties with healthcare access to retain their workforce. And then came COVID. So the pandemic has caused significant challenges for Colorado's healthcare system and exacerbated the workforce shortages across multiple disciplines and sectors of healthcare. So while the pandemic has had lasting impacts on the healthcare system across the state, whether urban or rural, regardless of the setting, rural Colorado is experiencing the most severe workforce turnover and shortages. Even before the pandemic, rural communities face challenges in recruiting adequate workforce, facing an aging healthcare community workforce and an aging healthcare community, as well as their aging workforce. We also saw some significant challenges presented by the constantly changing state and federal healthcare reforms. Rural healthcare facilities have been forced to face these workforce challenges by employing traveling providers, which can be really cost prohibitive. They've been cutting services. They've been requiring patients to travel longer distances for care outside of their facilities, and also relying more heavily on costly air and ground ambulance services. So to combat these challenges, rural healthcare facilities really need to be proactive and strategic about recruiting and retaining primary care personnel, which can be a challenge considering the current financial instability that I'll talk about a little bit later, and competition from urban facilities. So therefore, we really do need the state and federal government to support RHCs and make substantial statewide impacts on the healthcare workforce shortages. So some of the ideas that we have are establishing dedicated ongoing funding to offset facility costs of recruitment and retention. A priority should really be placed on initiatives that leverage educational opportunities for developing a homegrown workforce. So folks who are already living and working in our rural communities, how can we really empower them to continue to grow within their healthcare workforce career? Support funding for educational opportunities that leverage partnerships between rural healthcare facilities and local health institutions, and support policies that fund rural track medical education programs and expand rural residency slots. Now shifting to another policy priority that I'll cover today is financial sustainability. So rural healthcare nationally is facing a sustainability challenge. Nationally, we've seen 136 rural hospitals close from 2010 to 2021. We saw 19 closures alone in 2020. The majority of funds that are made in a rural healthcare facility do come from outpatient services that are often provided by an RHC. So the financial sustainability of RHCs is really essential. As I stated earlier, RHCs traditionally operate on thin margins and have been hit especially hard by patient volume declines and increased staffing costs spurred by the pandemic. RHC reimbursement rates often don't cover the cost of a visit. So again, folks are going to be dependent on that patchwork of grants, local support, donations, whatever they can get. But it often doesn't allow folks to grow or sustain any new staff or programs. You'll see kind of our rural versus urban payer mix. As I stated, we've got higher rates of Medicare and Medicaid, as well as a higher rate of uninsured folks. We're certain to see an increase in that uninsured rate as we see the Medicaid unwinding. Okay, so RHCs, again, public or greater rates of Medicare and Medicaid. This map, I think, really helps to illustrate the regional differences. We've got up to 94% Medicare and Medicaid combined in Costilla County, whereas you're going to see it a little bit lower in those resort areas. So one piece that I'll add that impacts the financial sustainability of RHCs is regulatory stress. So healthcare facilities are under severe regulatory stress after 4 years of intersecting state and federal reforms. In Colorado alone, we are seeing 17 major reforms being implemented, all on overlapping timelines. It can cause a challenge for state agencies and our facilities to kind of keep up with all of this. So temporary federal assistance also during the pandemic really did help keep many of our rural health clinics afloat and to avoid closure, but it really didn't have an impact on the underlying financial problems that we see at RHCs, which may cause an increase of rural facility closures as all of those federal dollars dry up. So rural healthcare facilities need to be paid adequately to support the costs of delivering essential services, and they should have the flexibility to tailor those available services to the needs of their local population. So some ideas we have, our policy priorities around financial sustainability is to include the AIR, the all-inclusive rate that's paid to RHCs, adequately covers the cost of care. Services currently provided outside the AIR must be carved out of traditional RHC billing, or they're not reimbursed at all, which can really be a challenge for administrative burden and all of that, even if you can bill. So again, this prevents sustainability challenges. We're looking to establish reimbursement for additional services that will help stabilize vulnerable rural healthcare facilities and allow providers the flexibility to provide more innovative services with an emphasis placed on value-based care. So some examples that you'll hear about a little later today is chronic care management and remote patient monitoring. Finally, we would love to encourage and promote investments in infrastructure, especially for aging facilities or facilities without a lot of technology infrastructure, really trying to continue on the momentum of telehealth. Okay, so I hate to leave folks with a doom and gloom feeling about the future of RHC, so I always like to end my presentation by highlighting the incredible value of RHCs in rural communities. So rural clinics are often economic engines in their communities. Rural healthcare facilities are often one of the largest employers in a community and can contribute up to 20% of the community's employment and income, often one of the top 3 employers. Healthcare is also a cornerstone in supporting Colorado's multi-billion-dollar statewide tourism industry, and that is across the state. Finally, one rural physician's employment can create approximately 26 additional jobs and support nearly 1.4 million in income from the hospital and clinic. So some really exciting things happening. If you'd like to learn any more about some of the things that I've covered today, you can check out the Snapshot of Rural Health and our Policy Priorities report. I'll be dropping links to those in the chat. But that wraps up my presentation. So again, here's my contact information. If you'd like to learn any more, please, if you have any questions, enter them in the chat and we can get them answered either right now or after our next presentation. I'm really excited to welcome Rachel Williams, who is our Hospital Programs Manager at CRHC, to walk us through the Healthy Clinic assessments that she and her team are performing at RHCs across the state.
Thank you, Kelly. Like she said, I'm going to do a quick overview of our Healthy Clinic assessments. This is done through our new grant opportunity. It's the Healthy Clinic Assessment and Workforce Sustainability Program. There are participating clinics that are receiving HCAs as part of the grant work from CRHC. And this is a grant funded by Kaiser Permanente. The purpose of the grant program is to identify areas for improvement to increase rural clinic sustainability. It comes in 2 parts, which is the HCA and then the APGAR workforce assessment, which you'll hear about a little bit later. But the HCA does include technical assistance and identifying those opportunities for business operations for improvement. This is a 2-year grant period and it ends in December 2024. And we have 17 clinics that are participating in this grant. So what is an HCA? An HCA does include a review of clinic's basic business operations, and it's meant to identify strengths and opportunities for improvement. There's many focus areas of the HCA, but it does hone in on patient experience, front desk operations, appointment, check-in, check-out, visit prep, billing, claim submission, coding, accounts receivable, and AR follow-up, We also do a review of your management of your clinic processes. The goal is to improve your clinic business operations to allow for greater sustainability of the clinic, as well as help the clinics move into quality programs for the future. Here is a quick overview of the HCA scoring. So each section has a certain number of areas or processes we're looking within the clinic in those overall focus areas. And essentially a clinic will either meet, partially meet, or not meet. And I did include the breakdown of those points for the assessment. We have shown that clinics with a score of 90% or better is a strong indicator of a well-functioning clinic, leading to clinic sustainability and easier to implement quality programs. Any clinics that are marked as partially, thanks, Kelly. Any clinics that are marked as partially met or not met within the assessment, they do receive comments for reasoning of the scores received, as well as resources and best practices for implementation to improve their scores in each of those sections. So the basic process for the HCA, what to expect before, we'll schedule the on-site day for assessment. We've usually say that we need a full day at the clinic, but depending on clinic size, it's usually just a half-day assessment. We also ask that clinic managers fill out the management of clinic processes form. This is a self-assessment. It goes over the clinic processes that they have in place currently, any continued education or training they do as staff, and any concerns that they have with their current processes. It's a helpful insight before we head out and are there on site to review all of their processes. And then we also ask to prep for staff interviews. We'll meet with clinic manager, front desk staff, either an MA or an RN, and then the billing and accounts payable staff, coding staff, and billing and accounts receivable staff. So during the HCA, like I said, it's usually a full day assessment, but sometimes it can be done in a shorter time period depending on the clinic size. And we usually like to show up before your first appointment scheduled. This allows us to view the patient experience as they check in for their appointments. The assessment includes observation of appropriate sections, which is mainly just the patient experience and front desk operations for their processes. And then we'll do interviews with key staff, which were listed on that slide before. And then we'll also review appropriate policies related to the HCA focus areas. So after we've completed the on-site day assessment, we sit down with the clinic manager or the team lead for the clinic, and we discuss any additional information needed for the assessment, as well as schedule a follow-up to discuss results and the process for improving their scores. So we take everything back from the assessment and we analyze the results and develop a report outlining their scores, findings, recommendations, as well as best practices. Once that report is provided to the facility, we do a follow-up call to fully review the report and answer any questions that they have, as well as put together an action plan, timeline, goals, and outcomes that the clinic wants to focus on from the results of the HCA. And then, as a reminder, in year 2 for this grant, we will complete a follow-up HCA, and this will be completed after the clinic has implemented changes. It's to see the success that the clinic has made while implementing those best practices or suggestions from the initial HCA. And that's kind of all I have as far as the HCA overview. We're very excited. We've done about 1/3 of our clinics so far, and we're traveling the next month and a half to do the additional clinics. So we're excited to see what data comes from it and improvements that the clinics make.
Awesome. Thanks so much, Rachel. We're really excited all the work you're doing to support our clinics and really excited to see the data that come out of the HEAs. We'll be sure to share that on our website, and I'm sure we'll be doing some targeted outreach to partners. Next up, we've got a spotlight on our Rural Connectivity Project with James Stevenson, who's the Associate Director of Health Information at CRHC. So take it away, James.
Thanks, Kelly. Yeah, my name is James Stevenson. I'm the Associate Director of Health Information. The Rural Connectivity Program is a collaboration between CRHC, OHI, HICPUF, CCMCN, and the Health Exchange Information sites here in Colorado, those two being Contexture and QHN. The program is designed to establish a sustainability model for rural connectivity, specifically to connect rural facilities, if they weren't already connected, to the HIE, supporting rural providers to adopt that health information exchange, data sharing, and providing analytics tools to support emergency responses, care coordination, and quality improvement. CRHC provides technical assistance and supports all of those items. And we also work with facilities to utilize the data within the vault for these efforts. This opportunity is making a difference with technology to assist our rural communities in helping to continue to provide and expand access to care and keeping it local. Basically, the goals of this project are connecting providers to Colorado's HIEs, supporting rural providers to adopt health information, data sharing, and analytics through implementation support, as well as providing analytics and tools to support emergency response, care coordination, and quality measures. Next slide. Perfect. So yeah, what's in it for rural hospitals? Well, first off, this is free. This is a free analytics dashboard that has aggregated data level for the respective organizations. Providers can also view their attributed patients and review ER and IP visits, pharmacy claims, utilization, costs, and just a whole bunch more. Next slide. This is an infographic that I really like. When we started this project, there were only 31 facilities that were actually connected to an HIE. As of today, we've added the additional 53 facilities that are connected to HIEs, meaning that they're sharing data, they're querying data through PC360. So yeah, that's huge. At the moment, we've touched roughly about 170,000 providers within rural, which the attributed patients and cases in the data vault are 1.6 million at this time. Currently, our participation in the project, we've got 70% of RHCs that are participating in the community analytics platform, and we have 81% of CAUs that are participating in the community analytics platform. And thanks, Kelly. Our data sources, so we rely heavily, of course, on the HIEs, CDPHE, which is our SIS agreement, which is immunizations, of course, HICPUF, civic provider information, labs, as well as working with the facilities to obtain TP authorization, which is the Medicaid 834 patient population, and also demographics. We work with facilities to pull patient demographics so we can kind of build that baseline data within the data vault. This right here is one of our newest reports that'll be coming out September 1st. This is our cancer report. Within here, the cancers are included: breast, cervical, prostate, colorectal, skin, melanoma, uterine, and lung. Within this report, there's quite a few views. We've got like cancer screenings, cancer diagnosis, treatment, mortality. You can also go into a patient population list. It's got an ADT summary as well as an 80 patient list summary. This is dashboard right here. It's actually live and in production. This is our diabetes dashboard. This basically provides insight into patient populations who have diabetes type 1 or 2, maybe pre-diabetic, recent high A1Cs, complications, recommendations for screening, as well as ADT messages that are basically provided to the facility to actually reach out to those patients that may be lacking in a particular screening that they need to be taken. Our vaccination report, we get this information from CIS via HIPPUF. This right now has COVID vaccination, but we're working with CCMCN and CIS to actually get in to kids immunization. So that's pretty exciting and should be around the corner soon. And this right here is just kind of a list of analytic dashboards that we have in production right now. As you can see, we've got, detailed finance and utilization, facilities claims analytics, pharmacy analytics, cohort tracking, visit details, actual versus expended cost, of course, ADT summaries, detailed finance and utilization professional summary, ER visits, pharmacy costs compared to like generic and non-generic, financial summaries, risk analysis, population health, of course, the diabetes report that we just went over, patient episodes, professional claims analytics, wellness visits, care coordination, chronic condition trending, as well as COVID management. I'm sorry, I kind of zipped through that, but if anybody's got any questions, there's our information right there. We do have some exciting new dashboards that are going to be coming up. One particular is our out-migration report. So we're trying to kind of like figure out why, our patients are not staying in their local facility to obtain that required just obtain the practice through the hospitals instead of actually going out and looking for those services elsewhere. So that should be a really interesting dashboard that gets created hopefully within the next couple of months. So, yeah.
Awesome. Thank you, James. It's been so exciting to see, you get that program up off the ground, and it's been amazing to see the data come in, see how our facilities are utilizing it, and see how we're utilizing it at CRHC to inform growing programs, having a better understanding of the health of the patients that we help serve. So thanks so much. Okay, up next, really excited. This is also a new program at CRHC. We've got our APGAR workforce assessments at RHCs with Sarah Leahy, Director of Member Services, Emily Vusta, Workforce Programs Manager, and Emery Shakiro, our epidemiologist.
Awesome. Good afternoon, and thank you everyone for having us and being here today. Like Kelly said, my name is Sarah, and I'm super proud and excited to introduce a project that we've launched for certified rural health clinics across the state just this year. I'm going to just give a quick background, and then I'm going to hand it over to my colleagues who are leading this work at our clinics. So like Kelly said, this program is called the Community APGAR program, and this is part of the grant program that Rachel reviewed earlier. The goal of the program is to address the primary care workforce shortages, specifically in rural areas across our country. The particular area of focus that we are looking at here at CRHC is at rural health clinics. So the Community APGAR program is a nationally renowned research-driven program developed by researchers, educators, and clinicians at Boise State University and their family medicine residency program. The concept of this research was to develop a test based on research that was quick and repeatable, similar to that test that is named after Virginia APGAR that is done on newborns. The data collected would then incorporate input and collaboration from the whole community. Results are used as a tool to assess the readiness for recruitment and retention of primary care providers in a rural health clinic and their community, and then strengthen the retention of those professionals that are already in practice at that clinic. Evidence has shown that through this assessment, findings underscore the specific community factors that play a role in the recruitment and retention of providers in a rural healthcare setting, and then help organize these factors for action. I've listed these main factors and I can review them as well, but as you can see, these are the factors that really we've seen and the research has shown that impact the rural health clinics recruitment and retention. And they include factors related to geography, economics, scope of practice, the medical support in the clinic, and then the hospital and the community support in the clinic.
Awesome. Thanks so much, Emery, Emily, and Sarah. It's such an exciting program. And I really wanted to underscore, Colorado Rural Health Center, we are the first organization in the country to be conducting APR assessments at RHCs. So we know that data will hopefully be used to inform future workforce legislation. And I'm sure that many of you elected officials who are on today's call will hear from me once we have some of that data to share. So now we're moving on to chronic care management at RHCs with our own Courtney Richards, who is the quality operations specialist. You're on mute there, Courtney. There you are.
Now can you hear me? Okay. I'm just going to go over what our chronic care management program is at CRHC. We have had 3 cohorts of the chronic care management with several clinics in Colorado. So the chronic care management program is where we help RHCs who face challenges with serving their unique population. These population of patients typically just don't have the resources they need in the area in order to manage their chronic diseases. And providers also fall short in the areas of having enough staffing and also having the resources to send the patients to. So with the chronic care management program, this will help them with those challenges. It is a program that is for Medicare patients. They are able to have 20 minutes of, communication with the clinics, with the patients' specialty providers, anybody that's involved in that patient's care. If they spend 20 minutes of time with that patient, they can bill for a chronic care management. So what this does is for these rural areas who have the higher rates of unhealthy behaviors, they have the less access to care, less access to healthy foods. They're usually like lower income, higher acuity patients. And with the CCM, that helps the providers get some type of reimbursement for some of those services they're already providing. Many of these facilities are already doing this work in the background. They're talking to these patients outside of the face-to-face visits. And so chronic care management does help that those reimburse for those patients that they're already assisting. You can go to the next slide. So chronic disease in America, as CDC shows that 6 in 10 adults in the US have a chronic disease and 4 in 10 have 2 or more. So they're the leading cause of death and disability, and the leading cause of the nation's 4.1 trillion in annual healthcare costs. You can go to the next slide. So the reason that chronic care management is such an important thing for the rural health clinics, As these statistics show, 91% of patients with chronic conditions say that they need help managing their disease. And then 75% of them want their provider to touch base regularly. You can go to the next slide. So because of that, the chronic care management in RHCs and in any rural facilities is extremely important. It can help change the way you interact with and care for your patients. Clinics that implement the CCM program experience improved patient engagement, which leads to better clinical results and an increase in revenue stream. CCM helps healthcare teams meet the patient where they are, helping them invest in their own healthcare and helping them to knock down the barriers to their healthcare or healthy goals. So benefits of the CCM program for patients. Patients enrolled in CCM, they get a stronger connection with their healthcare team. Since the chronic care management team usually consists of several people, the provider, the patient navigator, the MA, all of that encompass that patient in the CCM program to provide that increased communication. So that also gives the patient some more information on how to control their chronic diseases, how to prevent them from worsening. It lets them see how they can be involved in their own care and their own ability to prevent these from going into something further. The benefits for the providers that they, we all already have a lot of things on our plate, and it's really hard, to add more things to it. Luckily, like I said, a lot of the chronic care management is already being completed at your facility. This is just a way to get reimbursed for it and a way for you to work together in order to be better for your patients, those ones that need you the most. So not only will that benefit your patients, but it'll also be the revenue stream, and it'll help ensure that none of those patients fall behind, that don't get what they need from their provider. So, any chronic care management program is going to take the work in the beginning to get established. But once it is, it really becomes a great program for everybody involved and does become a real good revenue stream. You can go to the next slide. So we are getting ready to start our cohort 4. The kickoff for that would be in October. So what this is that we will help you develop your chronic care management program for your facility. We help you organize your team. We walk you through the different components of the CCM program, and we help you implement and improve your CCM process. You'll have access to like a network of rural clinics working through the same initiative. You'll have connection with a billing and coding specialist, and you will have access to rural clinics that have a successful CCM program in place. So if you're interested, your facility is interested, somebody that is, just send me a message at krichards@coruralhealth.org. And we will put you on our list to contact when we start our next cohort.
Awesome. Thank you so much, Courtney. You've done some amazing work really supporting our CCM program. We know it's an incredible way to help our patients improve their outcomes while diversifying a revenue stream for our members. So a real win-win program. I'm going to pause here. We've got just a couple minutes. I just wanted to see if there was anyone in the audience who had any questions before we pivot to the next part of our presentation today to hear directly from some of our RHC members. So any questions or comments on any of the CRHC programs or topics that we've covered so far? All right, well, staff will take that as a signal that we're doing an amazing job presenting. So next, we've got Jaden Miracle from Family Practice of Holyoke to talk to us a little bit about how they have implemented a remote patient monitoring program.
Hi, everyone. Can you hear me?
We can hear you, yep.
Perfect. So I'm really excited to talk to you guys today. We have a really fun program through remote patient monitoring, and it kind of ties into what Courtney was talking about with care management and how you treat the patient as a whole. It's been really important to our practice. So if you want to go on to the next slide. So some learning objectives are how to build a remote patient monitoring program, collaborating with your primary care providers, building RPM sustainability, RPM workflows, and then optimizing RPM to enhance chronic care management outcomes. Next slide. So our strategy first started when COVID first hit. During the COVID pandemic, there really was a need to provide virtual care services to our patients, keeping them safe, keeping them at home. And then in a rural community, patients travel great distances to come and receive care. So we really wanted to provide that opportunity for our patients to better be engaged in their care from home. And so that really led us into remote patient monitoring. We had kind of talked about it for a few years, but COVID really initiated it with the need to social distance. So that really led into the community initiative. A lot of our patients said, we really want to be engaged in our care plan. So that's when we went out and looked for some grant support. We were able to obtain a grant from the Office of eHealth and Innovation, which allowed us to purchase our own devices that we could then loan out to our patients or lease out to our patients, which fostered consistent collaboration with our providers and our population health nurse, engaged patients in their care plan, and then ultimately led to the team-based care model that we were trying to implement within our clinic. Next slide. So remote patient monitoring, some of the chronic diseases that we focused on most is our hypertension and diabetes, but we also do all other types of chronic conditions through our care management program. But really what remote patient monitoring allows us to do is to engage our patients in their care, improve health outcomes, and then provide a team-based care model for all of our patients. So next slide, please. So in order for us to provide RPM services, we needed to get a virtual care platform. We selected CureView, which is an online platform that integrated with our EHR, our electronic health record. And it allows us to do e-check-in, telehealth appointments, patient campaign messaging, chronic care management, remote patient monitoring, and then provide a white patient label app for our patients to submit their health data. How this essentially works is the provider is able to send an electronic referral in our EHR over to our population health nurse saying, I want this patient to be enrolled in our RPM program. Then the patient is enrolled in the program. Our population health nurse meets with them one-on-one, shows them how to utilize the equipment, sets up their smartphone device or a tablet. We also do provide tablets if they don't have a smartphone device. And then they have that two-way communication from the population health nurse to the patient. And then if anything is abnormal, the population health nurse would immediately go to the primary care provider to also reduce the chance of readmission or ER visits and hopefully get them into the primary care practice. Next slide. So some equipment that was purchased is one of my favorites is actually our biometrics performance monitor. So cool. It does 3-lead EKGs, and I'll talk about a success story later on that. But we also purchased a Bluetooth scale, Bluetooth blood pressure cuffs, a fitness tracker, tablets, and hotspots. And essentially the way our program worked is we knew we couldn't partner with an organization or a company to pay a percentage of the RPM back to the company to loan their devices out because we're not making any money off of our RPM program. So we purchased our own through the grant. And when we lease the equipment to the patients signed contracts saying that they're not going to misuse or abuse the equipment and that it will be returned when they are able to manage their chronic conditions on their own. And then each patient is provided a one-on-one training with our population health nurse to really go over on how to use the equipment and how to submit the health data, as well as develop their care plan. So the patients are really engaged in the creation of their care plan so that the goals are obtainable and realistic. And then, oh yeah, and then the application. Sorry, you can go the other way. So some best practices that we've kind of realized through the work is identifying patient cohorts. So one example that we just did this previous year was our hypertension cohort, that we're able to identify our patients through utilizing our EHR and claim-based data for patients that have hypertension. And what we did is we provided that list to all of the primary care providers. Here are your patients that have hypertension. They then identified those patients that they think would qualify or do well on RPM. And they sent over referrals to our population health nurse to help do that outreach and help get them enrolled in our program. We also utilize MIPS reports through our EHR and identify patients that are unsatisfied, not meeting the MIPS measure for diabetes and hypertension. And then those patients are either reached out to have more E&M visits or are enrolled in RPM as well. And then we report to QHI, which is a quality health informatics system that we support. And that helps us track our data monthly on where we're trending with our hypertension and diabetes management. Referrals are also sent over using RPM, PCM, which is principal care management. I'll talk about that a little bit later, chronic care management, and community events. We've actually sat up at the local fair, talked about our programs, provided free blood pressure checks, and we've also provided walking Wednesdays. Every Wednesday we have walking Wednesdays where our nurse actually goes to the track. These are really great community outreaches because it helps us share our program, and then our program actually spreads by word of mouth. We actually have patients that will call and say, I heard about this program from my friend. So community events are great. And then we also do well visit campaigns, encouraging patients to come in for well visits and see their primary care provider to hopefully get them enrolled in the program and help better manage their chronic conditions for the long run. Next slide. So this is an example of a hypertension workflow. So a patient is essentially diagnosed with hypertension. The referral is sent over to the population health nurse, and then the outreach is made to the patient. The patient is engaged in their care plan, and a standard medication treatment plan is put into the patient's chart. So they know exactly what they need to follow. The equipment is then provided to the patient. They sign the contract, it's leased to them, and then they start reporting weekly blood pressures to the population health nurse. It can even be daily. It really depends on the patient's needs. And then the population health nurse reviews and consults with the primary care provider on any lifestyle changes or changes to the medications that need to be made. And then once the hypertension is managed, the patient will return the equipment back to us. Next slide. So diabetes workflow. Diabetes, basically the patient is either newly diagnosed with diabetes or is unmanaged and really needs more education and a better developed care plan for those lifestyle changes to occur. So an electronic referral is sent over to the population health nurse. The population health nurse then reaches out to the patient, enrolls them in the program. We do provide CGMs or continuous glucose monitors for our diabetic patients, and they can report their blood sugars on a daily, weekly, monthly basis to the population health nurse. And then the population health nurse provides monthly education and lifestyle coaching to that patient, as well as consults with the primary care provider on any changes that need to be had. Or if anything is abnormal, then it's a little bit more urgent and they'll do direct outreach to that patient. And then labs are ordered on a 3 to 6 or 12-month interval, depending on the patient's needs. So really exciting things is our improved health outcomes. So we started this back, we got a grant late 2020, started this work in 2021. And in year one, we had 94% of our patients had a reduced ER or hospital admission during the first year, which is huge. That's the goal of the care management programs, is to keep patients out of the ER and keep them in the primary care setting to reduce costs. And then our diabetic patients, 85.8% of our diabetics have an A1C less than 9, which is really a high percentage of managed patients now. And then hypertension has improved by 9% from July of last year to current. So we, like I said, we just started our hypertension sprint last year in an RPM enrollment. And now 88.4% of our patients have a managed hypertension or blood pressure. And then because of that hypertension sprint, we had an increase by 67% enrollment in our RPM program. And we have 42 patients currently enrolled in RPM. And we only have 50 devices. So we're almost at max. We have created a graduation program on how we can start getting patients that are considered managed to return their equipment and start focusing on some other patients that have other high complex needs. Next slide. So some patient success stories. During year 1, when we first used the biometric performance monitor, we had a patient realize he had an irregular heart rhythm. And so he called the population health nurse and he says, my biometrics performance monitor is telling me I have an irregular heart rhythm. She's like, okay, you need to go to the ER. And because of that, we were able to provide early intervention to this patient and caught a heart attack, and were able to get that patient early care, which is a huge success story. And then we have this wonderful diabetic patient that religiously submits her A1C levels and was unmanaged at first and is now very managed. So really cool success stories. We love our patients, and our population health nurses do a great job. Next slide. So reimbursement, obviously it's important to be reimbursed for the care that you provide. It is a little bit different on how you can reimburse. So currently Medicaid does not reimburse for RPM services. I would love eventually for them to reimburse for RPM. Some private insurances do pay for RPM, such as UMR, Blue Cross Blue Shield, and Anthem. But currently the way that we bill Medicare patients, this is for Medicare patients because Medicaid doesn't bill for it. This is an example of what reimbursement would look like using the HCPCS codes. So principal care management is 30 minutes or more spent with the clinical staff, focusing on one chronic condition that will last at least 6 months. And then chronic care management is 20 minutes or more spent with clinical staff on the patient that focuses on 2 or more chronic conditions lasting at least 6 months. That needs to be reevaluated every year. So next slide. And that's my contact information. That's all I have for you guys today. But really excited about our program. And thanks for having me, Kelly.
Awesome. Thank you so much, Jaden. Your program has been a real inspiration. Just know that at CRHC, we are working proactively on legislation to get Medicaid reimbursement for those remote patient monitoring services. So really appreciate all your hard work and initiative. And again, now we are excited to also hear from another RHC that is also implementing some exciting pieces around remote patient monitoring as well as team-based care. So I'm excited to invite Audrey and Alyssa from SLV for our final presentation.
Hello, thank you so much, Kelly, for having us speak here today. Yes, Jaden, that was very inspiring. We're going to have to connect with you on RPM because we are in the very early stages, but you'll see that here in just a moment. So Audrey and I are going to present on team-based care and RPM. So we're going to take you through who we are, our clinics and who we serve, as well as team-based care, kind of the history of the grant, our current grant and our progress, and then as well as RPM. So next slide. All right, so who we are. So my name is Alyssa Kanugi. I'm the Director of Operations for Primary Care. And then in a moment, you're going to hear from Audrey Richloy, who's our Director of Programs. And our rural health clinics are Antonito Medical Clinic, Lahara Rural Health Clinic, and Monte Vista Community Clinic. And who we serve is the San Luis Valley. So they span across this wonderful little infographic you have here. And so we have quite a few rural health clinics, but we're going to talk to you a little bit about team-based care in those clinics. Next slide.
Hey, hi, everybody. Thanks for having us I guess it's afternoon now. It's great to hear all of the awesome work going on across our state in the rural space. Wanted to just spend a little bit of time talking about team-based care on the ground level in our rural health clinics. We hear this phrase a lot, but at San Luis Valley Health, we really live and breathe the team-based care model. And so just to provide a little bit of context, when we say the term team-based care, what we're really talking about is the term that was defined by the National Academy of Medicine as the provision of health services to individuals, families, and/or communities by at least 2 healthcare providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals. And it kind of goes into the 5 core principles of shared goals, clear roles, mutual trust, effective communication, and measurable processes and outcomes. Those still feel like really lofty, high level sort of definitions. And so to get into the nuts and bolts of what it looks like in our clinics, we utilize the 10 building blocks of team-based care. And those include having engaged leadership. And when we use the term leadership, we don't necessarily mean those at the top. We mean anybody who identifies as a leader and has a voice within decision-making power. We utilize data-driven improvement methods and best practices. We follow empanelment. So we ensure that every patient is empaneled to their chosen identified provider. We do this using either a 4-cut method or a patient choice. We implement the tactics of a team-based care approach as listed in that definition provided. We feel strongly about the philosophy of patient and team being in partnership with one another for achieving mutual goals. We have a strong emphasis on population management. So as many of the presentations have already outlined today, ensuring that we are looking at data to drive outcomes and ensuring that we're caring for the population as a whole that we find to be unique in the San Luis Valley. We have a strong emphasis on continuity of care. And when we use that term, what we're really specifically meaning is what's the percentage of times the patient saw the provider that they're empaneled to versus other providers either within our system or outside of our system. And our goal right now is, I believe, 70%. We also look at prompt access to care as the 8th building block. And so when we say this, we're relying again on very specific definitions and data, meaning for our clinics, we look at third next available as well as capacity of those providers to see those patients at the rate that they need. So ensuring that we have acute care slots as well as ED and hospital follow-up slots available within that context. We look at comprehensiveness and care coordination. So a huge piece of team-based care includes having care management. We talked about CCM earlier today, having care navigation, as well as integrated behavioral health and other supportive programs. And then finally, building block number 10 is a template for the future, meaning that we take best practices that we develop through our PDSA process or other improvement projects. And if something works, we try to not only sustain it and hardwire it, but also spread it to other locations. And so as we think about those 10 building blocks, that's really our definition when we say the term team-based care. And what that has looked like historically at San Luis Valley Health, we were fortunate enough to get a 5-year grant through the Colorado Health Foundation back in, I want to say 2013 or 2014, and that ran for 5 years. We had technical assistance and tons of team support. And the initiative was so neat because it was really developed at sort of a grassroots level, if you will, where we brought together our frontline staff to design the implementation of team-based care in our clinic. We targeted our Alamosa clinic, which is our main clinic, our largest clinic, I should say, within our system, to be the pilot, if you will, for implementing team-based care. And through that project, we focused on improving our defined roles and having everyone work within a pod model to really ensure that patients were empaneled to one specific primary care provider. And if that provider wasn't available, they would see another provider within their pod so that the pod had that relationship and continuity with the patient. We were also fortunate enough within this space to receive a supplemental award through the Colorado Health Foundation where we renovated our physical space, because a huge component of successful team-based care is geography. So ensuring that the team is together, that all of the roles are represented, that there can be successful huddles, and that that team can support the clinic exam rooms right from that space. And so it's huge. Geography is a huge successful piece to this work. We worked at standardizing our workflows and ensuring that teams were trained on those workflows. And a big piece to that was to support coverage, so that if a CMA had to cover a different provider, they understood what those workflows looked like to successfully kind of implement that PODS model. We stood up standing orders and helped all of our clinical staff work at the very top of scope. So what we found at the beginning of our work was that our providers were doing a lot of workflows and standing orders that could have been provided by other functions on the team, and so had to completely redesign roles and implement new training models to affect that. We hardwired the new team members, care coordination and integrated behavioral health, and got those implemented within the team. And then at the very tail end of our 5-year grant, we moved into sustainability and spread. And that was really where we found that we had some struggle. And so a huge component of that was, of course, COVID. Having COVID contribute to some pretty significant turnover and staffing challenges within our clinic, right up against the end of this grant and our initiative to spread the work, caused us to kind of run into some challenges. So lucky for us, we were able to then apply, next slide, please, for a new grant through the Colorado Health Foundation, where they've actually revamped their team-based care grant and allowed us to reapply for this fund with the goal of exactly what we described, taking the foundational work that we'd already developed, building upon it with these other components listed here on this slide, and then spreading it with more intention and resource to our rural health clinics. So with this new 2-year grant through the Colorado Health Foundation, we not only have the ability to dust off what we did with team-based care and implement additional and more hardwired strategies in our rural health clinics, which we'll talk about in a moment, but it also required us to add in a couple of additional components, which again, we've learned through COVID-19. One was the necessity and imperativeness of having a targeted look at diversity, equity, and inclusion, as well as health equity. So as we all know, COVID-19 put a spotlight on an already huge issue that we had in healthcare, which were disparities in health as a result of diversity, equity, and inclusion gaps. And so the nice thing about this grant is it provides us some additional technical assistance to support that effort. And then also a targeted effort and resource around technical assistance for sustainability and strategic planning. So we're able to not only implement these services at this higher level of function, but also really evaluate what is our long-term strategy for ensuring that we can sustain these services within our rural healthcare clinics. Next slide, please.
So team-based care right now in our RHCs, what does it look like? So we started off this 2-year grant with an assessment, a very lengthy assessment that really put into perspective where we were as clinics. So like I mentioned, we have 3 rural health clinics that just joined this grant along with our Stewart Avenue Primary Care Clinic. And we identified that each clinic, although they're within the same system, have very unique needs, and each clinic have different resources. So with that, we kind of came up with a plan for each clinic, and we set up core teams in each clinic to go ahead and address some of the things that we came across in our assessment. Halfway through the grant, so the beginning of this year, we identified that, we needed to have a much smaller group, have more control over what was going on in the clinics, and work towards a more standardized approach to some of these things that we were noticing in team-based care. Because while each clinic is unique, we noticed that some of the areas for improvement really were the same. So we established a smaller core team comprised of 1 representative from each clinic, and we meet on a monthly basis to go ahead and determine what our goals are and kind of set timelines on our goals. And so some of those goals that we have surround team-based care itself, or diversity, equity, and inclusion, which is a big part of this grant as well. And so the goals that we had set up were for planned care and huddles, empanelments, staff training, language access, and a space audit. And so planned care and huddles, we were really wanting to ensure that each clinic had the opportunity to successfully perform huddles within the clinic. And what huddles are really comprised of is each team member brings from their group some information to the huddle to go ahead and discuss kind of patient management schedules, whatever it is that we assigned. And we're actually going through those roles again, just to ensure, because as Audrey mentioned, COVID happened and we had significant turnover. And so what that looked like is we are actually missing maybe some care coordinators in some of our clinics. We're missing maybe behavioral health. And so that really established some gaps for our team. And, again, medical assistants as well have turned over before. So just making sure that we stay on track with our goals. And so really huddle management is one of our biggest goals, and how we incorporate our admitters and our schedulers into that. The next core team goal we set was for empanelments. As Audrey had mentioned, there was a lot of work around empanelments at the beginning of the first grant and throughout that first grant. And what we've noticed is, because in rural clinics, typically we do have some patients that like to maybe go to some of our clinics for acute access, or they like to maybe try to jump around a little bit. So how do we manage that moving forward? We put a huge emphasis on empanelment scrubbing, making sure that we have accurate data. And then the last one for team-based care was staff training, ensuring that we have a sustainable approach to staff training moving forward for team-based care. So how does that look like during orientation of new hires? How does that look like right now? Is everyone clear on their role within the team-based care model? And so we're working through that right now with some of the resources that our team-based care coach has given us. With DEI language access, we have a very diverse population that we serve. So ensuring that we have language resources available, what that looks like, and making sure that we have forms in clinic that are in both English and Spanish, and making sure that we have the ability to go ahead and have an interpreter through MARDI, which is our electronic interpreting system, go ahead and ensure that patients know what they're discussing with their provider, with their care team. And then a space audit, lastly, making sure that, our space is inclusive to all population types. And so we actually had quite a few initiatives in that space audit. One of our rural health clinics actually went around, we had groups go around in wheelchairs, making sure that, we could access all areas within the clinic. And they were really engaged in that process. They were really wanting to make sure that our patients felt safe and comfortable. Now, so some of the successes, of course, of what I just mentioned, we have some clinic team leads who are leading some of these initiatives. We have lists of trainings that we're wanting to ensure that people that we do within this next year. And, we have a really engaged core team at this point. And so we're really excited. We have been able to send our core team to team-based care forums that they host twice a year in a calendar year. And it's been really great to see the team engaged in this process. Some of the challenges, as I mentioned, each clinic is unique and they have certain resources. They do not have other resources. And so just making sure that we kind of manage on that. Diversity, equity, inclusion is still a very new subject in healthcare, and just trying to get adequate amount of education on that. We have some mixed feelings about that as well. And so just making sure that we can maintain a positive outlook on what we're trying to achieve and what we're trying to do for our patients. Next slide, please. So now we're going to go into remote patient monitoring.
Okay, so I think the team prior to us did a phenomenal job explaining what remote patient monitoring is and what it entails. And it was exciting to see because so much of what they are ahead of us on matches the work that we're in the process of implementing. So I won't go through a ton of detail there. So thanks for that softball lob. I appreciate it. But similar to the group prior to us, we also were awarded a grant out of the Office on eHealth Innovation. We only received that grant back in 2023, November of 2023. And so we are just getting started with this, but similar to what was already presented, we're really hopeful that it will have a huge impact on reducing hospital readmissions, reducing length of stay in our hospitals, and also support the efforts we've already described in team-based care regarding our population health efforts. We have entered into a contract with RPM provider called Health Recovery Solutions. We went with this specific provider in part because they seem to have a really good grasp on our rural space, meaning that when they are connecting individual patients with SIM cards for the RPM technology, they have a map and they look at where that patient lives in relation to broadband access. And so they try to connect patients to the specific SIM card that matches up with the best chance of having connectivity and reducing some of those connectivity issues that I'm sure we all face as rural providers. They also have an incredible track record for working with patients who have an average age of, I believe, 80 years old. And so while they do provide hands-on orientation and training to patients right at the beginning of getting set up to make sure that they know how to use the technology, we also wanted to go with a provider that had a really good track record for the technology to be super user-friendly and accessible. They, similar to what was provided before, they manage all of the hardware for us. So while we purchased the equipment and then therefore have patients sign that waiver, or I should say that acceptance of responsibility, and we loan them the equipment, and this company allows us to mail the equipment back to them. So they clean it up, they get it all stripped and ready to go before they send it out to the next patient. So it's completely managed on their end, which was really nice because like every other staffing challenge we face, certainly having available tech staff to manage this hardware and provide that support to patients directly was not something we had available. And so this has been a really helpful resource. And finally, and this kind of ties into challenges that we'll talk about in a moment, through our contract, we've also entered into a contract through HRS with a third-party nursing company. So a big area that we wanted to ensure support for was regarding what do we do if a patient has an alert that comes in and we're busy with other patients? Or how do we ensure we have the right level of staff that can support some of those more complex medical needs that come through with RPM? And, you know, we don't have a ton of RNs available within our clinic system. And so we entered into a third-party contract with a nursing company who not only monitors the feeds coming through and can kind of flag those higher alerts and provide some immediate support, but also can sort of provide some of that continuity of care and care connection for the ongoing support that maybe our team doesn't have that readily available. We are just at the kickoff of this program. So like I said, we got our contract back in the fall of 2023. We're working with a ton of stuff behind the scenes to figure this out. So I will be reaching out to the folks from our presentation previously. But because of that, we wanted to do what we do typically at SLV Health, which is identify a smaller population, pilot something, work out the kinks, and then spread it to a larger group. And so right now, we're focused on cardiology. They do an amazing job of supporting our patients who are inpatient with the transitions of care. And so we're lucky to have an embedded cardiology team that's willing to take this on. We're also looking at supporting depression, believe it or not, with this technology, which is maybe a less traditional condition with RPM. They do some daily and more frequent screenings of patients with PHQs and send alerts to help kind of monitor that. And then finally, we're looking to build this within our discharge process. So San Luis Valley Health is a clinic system within a rural hospital system. And so we want to see how we can implement RPM as maybe an additional resource patients can go home from the hospital on, that may or may not have an impact on reducing length of stay and supporting reducing readmissions. We, of course, are facing challenges, which I'll let Alyssa kind of kick off.
So, I mean, with operations, and I know that we're running short on time, Kelly, so please let us know if you want us to, okay. So of course, with operations, just, what does this mean for our providers? What does this mean for our care team in terms of time? And then, of course, as Audrey had mentioned or has on these slides, is the billing in general and Medicaid, and ensuring that we have an engaged team with this process. So part of that is just working out the kinks with workflows, working out, what resources do we have available and what does time look like in the clinic, and how do we not impact our patients in clinic. So one of the workflows that we're working on right now is ensuring that we have kind of a set timeline as far as how often are providers needing to be looking at the dashboard. We're very fortunate to have that third-party contract. As Audrey had mentioned, we have some challenges with, as far as clinic RNs, we don't have very many. And the ones that we do have are, providing different kinds of services across the clinic division, our clinic division, that really holds them at a lower ability or lower capacity to be able to take on this project. So again, just those challenges come into mind. But I think one of the things that we have to continue to remind ourselves, as Audrey mentioned, this is a very small start, very small pilot. There are only 30 to 40 patients that we're really looking at assigning to a remote patient monitoring. So we just have to keep positive and hope that we're able to kick this off successfully. That way we can expand it to other clinics.
And just to piggyback on that piece, it was mentioned already, but we will continue to appreciate support around advocacy for RPM to be a billable service for Medicaid. I know this was mentioned previously, but certainly, it's a primary payer for our population, and we just see so many potential good outcomes. And so we're fortunate to be working with the Office on eHealth on trying to navigate how we work within Medicaid through the course of this grant, but it does pose a challenge. And then we're also running into a little bit of an interesting question mark around House Bill 21 in terms of making sure that we screen all of our patients for discounted care, and how we work within that when folks are being provided care remotely on purpose. How do we ensure that they get screened and we are within the rules, but also recognizing that it's a hardship for patients to come in physically, and that's the whole purpose of RPM. So how do we navigate those two pieces together? Next slide. This is just a fun little picture. These are the folks from the state who fund our grant. They came down for a site visit, and we got to show off some of our equipment. So we were pleased at how that site visit was. So it's just a little fun picture. Next slide. And that is our presentation, but feel free to let us know if you have any questions. Thanks for your time today.
Great. Well, thank you so much, Alyssa and Audrey. We appreciate you both very much for being on. Thank you, Jaden, again for presenting as well. And thanks to all the CRHC staff for putting this together. In particular, thanks to Kelly for putting the whole program together and doing all the outreach for this. Appreciate that very much. And happy Safety Net Clinic Week. If you need anything, please don't hesitate to reach out to any of us at the Colorado Rural Health Center, and we'd be happy to answer any questions you have. Take care, everybody. Thanks.
Thank you.
Everyone.